Good morning. My name is Zach Brown. I'm a trauma, burn, surgical critical care surgeon here at Naval Medical Center Camp Lejeune. And I was given the opportunity today by Dave Grovedal to talk with you a little bit about who I am, what my background is, and what we're trying to bring to the table here at Naval Medical Center Camp Lejeune. So a little background on me. I'm 14 years active duty with the Navy. I did my first 4 years as a general medical officer right here at Camp Lejeune. A couple years with artillery, 1 year with anti-terrorism, and 1 year with infantry. I did a general surgery residency in York, Pennsylvania, followed by 2 years with Fleet Surgical Team 6 based out of Norfolk. I then did my burn, trauma, and critical care fellowship at Parkland and UT Southwestern in Dallas. And immediately thereafter was assigned to Walter Reed. Pretty soon after arriving there, I got to deploy again, and during that time learned that this trauma center was trying to get off the ground, and jumped at the opportunity to come down here and be a part of it. So here I am. I've been here since November, and have really gotten a feel for the commitment, not just locally within the hospital, but locally within the community and the state, how this is really the right time and the right place for everyone involved. And we've seen tremendous support from Onslow County and quite a bit of support from the state as well to make this happen and bring trauma care to Onslow County. As a level 3, the vast majority of what we do is stabilization. We don't have a lot of subspecialties like neurosurgery, and that can be a big rate limiting step for a lot of these falls and car crashes that have a head bleed or spine fracture that's unstable. And so for those, we stabilize and ship. But for some of those, already our presence has been life-saving. Just a couple of months ago, I had a motorcycle crash with terrible pelvis injury. And I have very little doubt that despite the best transport available, that patient would not have done well in an hour transfer. He needed that initial stabilization, some blood early on, and then he was successfully transferred to Vidant and has done quite well. So we're pleased to be a part of that and to offer those services. Hopefully the best is yet to come. With burns, to the best of my knowledge, I'm the only burn surgeon in the Navy, kind of a rare breed. And again, I feel very blessed to be able to bring that skill set here to Camp Lejeune, because honestly, the majority of what we see are partial thickness burns, usually of the hands, in kids who fall against a stove, touch an oven, touch a hot pan, fall into a campfire, things like that. And partial thickness burns, what used to be called second degree burns, are usually non-operative, just some good local wound care, and in 2 to 3 weeks they'll heal up on their own. The problem to bringing burns to anywhere that isn't a burn center is that the American Burn Association, or ABA, has very specific criteria that if you meet them, it pretty much mandates a transfer to a burn center. Well, the reason that came about is that most non-burn centers don't have a burn surgeon work in there. And the simple truth of the matter is there are a wide variety of burns that can be handled quite well at a hospital that is prepared and committed to that task. And we've started that process here, getting physical therapy, occupational therapy, wound care, the nurses on the floor and in the ICU, dermatology, and the operating room staff all on board to manage burns. But a good discussion to have is also with EMS, because you are the first triage step in taking care of burn patients. And so I wanted to talk a little bit about what we will and will not see here. In other words, what things can you immediately bypass us and fly somewhere else, versus what's appropriate to bring here for us to take a look at and weigh in and say, yeah, we can handle that, or hey, thanks for bringing them here, we're going to stabilize them, but yeah, they do need a burn center, and sending them on to either Vidant or UNC. So some of the things that we definitely don't see here, or will not be able to care for long term here, are patients with inhalation injuries. So anyone that you pull out of a house fire that has been in there for longer than a couple of minutes likely will have an inhalation component that will require specialized ventilator capabilities that we don't have here, like an oscillating ventilator. So those will need to go on. Patients with electrical injuries. This is something that I tell in my burn lecture, that the skin lies when it comes to electrical injuries, because all you'll see is a teeny tiny entry point and a teeny tiny exit point, and everything connecting points A and B is potentially damaged beneath the skin. So they can have pretty rapid kidney failure requiring dialysis. They can require huge resections of dead muscle tissue. Of course, there's potential cardiac problems that go along with it. And so those patients, if they're fortunate enough to survive the initial injury, really do need the specialty care of a burn center. Right now, there's nothing that we exclude as far as an area of injury. So even if you have a full thickness on face, hands, feet, genitalia, perineum, those can all be brought here for evaluation. And then we'll make the determination whether or not it's something that's in our wheelhouse. Right now, we're limiting the total body surface area of burns that we manage here to around 5 to 10%. But that doesn't mean that we can't be a part of the stabilization process in initially caring for people with larger burns, get their intravenous access established, get their resuscitation going, secure their airway before we send them along, because let's face it, it's a long trip up to UNC. So what can you all do, or what should you do when you first get a burn patient? Well, first thing is scene safety. Make sure you're taking care of yourself. Make sure you have the right equipment and that you're not the ones running into the fire without the necessary personal protective equipment. If it's an electrical source, make sure that the burn source is de-energized, because frankly, I don't need 2 electrical patients. And then stop the burn itself. So if it's a dry chemical, brush it off and start flushing copiously with water. You're going to soak the back of your rig, but whatever you have on hand, start diluting it out. If it's a liquid chemical, you can just go immediately to diluting. Get any contaminated clothing off. If it's a thermal burn, like a fire, get the clothing off. Expose the area so that there's not a plastic type material or a synthetic that's going to melt to the skin and become a problem getting off later on. So rule number 1 is stop the burn. Rule number 2 is the same as any other trauma patient, ABCs. Get oxygen on them. Make sure that you have circulation established with access. You can put an IV through burn tissue. That's not a contraindication. Large bore is preferable. So these are the ones that you really want, the 16 and 18 gauge. And make sure you secure stuff in place because they're going to swell up. And it's heartbreaking to lose access after someone's already puffed up like the Michelin Man. I would ask that you not hit patients with a ton of fluid as a bolus right from the get-go. Just start them on a nice low rate of LR, not normal saline, LR. That's our fluid of choice for burn resuscitation. Keep them warm. You're going to be sweating in the back of your rig, but crank up the temperature, 95 degrees. These people have lost their ability to thermoregulate, and hypothermia can become a big issue. You don't need to put on any type of lotion or cream, no Silvadene, no bacitracin, nothing like that. Just dress the burn with a clean dressing, whether that's a clean sheet or some Curlix, a nice loose wrap to cover things up until they get to our facility. And once you get there, if the room is loud, we've already run into this a couple of times, you are the most important person in the room when you show up in the trauma bay. Use your big boy voice or your big girl voice and give us the information that we need. An effective handoff only takes about 30 to 60 seconds, where you tell us what happened and what you've done. It lets us know where we're at and where we're going. And that's really the continuum of care right there in a sentence. Where we're at, what we've done, where we're going. But you are in charge of that moment when you come in. If you're not getting the assistance that you need, look to the team leader, who's either going to be the ER physician or the trauma surgeon. We'll be the ones wearing the green hat. And ask us if we can help you control the room. It needs to be quiet so that everyone can hear, not just us, so that we're all on the same page. And I think that pretty much sums up what I wanted to tell you about burns and what we can do here. I'm sure there are going to be lots of questions. Feel free to email me at Zachary, ZACHARY, .w.brown.mill@mail.mil, and I'll answer your questions individually as they come in. And thank you so much for what you do and for helping us to become a trauma center. We couldn't do it without you. And look forward to meeting each of you as you bring the bodies in.